I can only answer from an antitrust perspective. We don't directly look at risk. We are looking at competition. One thing that we have realized when looking at these dynamics between providers, sometimes dominant providers, and health plans, is that the whole question of who's going to bear the risk is very much part of the negotiation that occurs. So the more dominant a health plan is, the more dominant a health plan is, the more likely the providers are going to be bearing a significant amount of the risk. In situations where there is a dominant provider, it is more likely that the risk is going to be pushed back onto the health plan, and the dominant provider is much more in the fee-for-service business than you might expect.
So clearly the risk pass, who bears a risk, I mean, I think has an impact on, in some senses, certainly has value, right? That's why whoever's dominant is going to push it on the other person. But also, I think it also affects potentially the level of competition, which is what you're looking at when it comes to antitrust, right?
That's right.
So because there's also then the question is who else is willing to come into the market to try to bear that risk after you agree to whatever agreement comes to there, because now you've established this standard in that market around that hospital or of that.
That's right, and it's a very fact-bound situation, so that it's very difficult to generalize. Mm-hmm.
Well, I would just say that the Department of Managed Healthcare also looks at provider contracts, and as part of our process is how are those going to change with the merger, if they're going to change. So we do get, template contracts to review as well.
Well, and this isn't related to the risk-sharing issue, but because you raised a few different issues in the discussion there. If we get to a stage where we have fewer carriers and there are therefore fewer choices in the market, I think that the reviews that we do now on some of the products, it will be even more important. It is not uncommon for products to be submitted to the department where we feel like that the design of the product has either an intended or an accidental impact that would be discriminatory against folks with certain medical conditions. And so, we really do try to hone in on that and get all of those things out of the product before they're sold. But we will see going forward, if you have fewer companies that you're regulating, I think the regulator's job becomes more difficult to get the companies into compliance with the law. And it will be important to try to facilitate a situation where consumers do continue to have real choices.
So I have a question first to the Department of Justice. Obviously, what you look at is antitrust, limited also to nonprofit hospitals for sales. And listening earlier to the Massachusetts model, do you feel that if we had a model similar to that here to bring transparency to an issue, work in collaboration with the Attorney General, is that something you think that you would find beneficial?
Sure, I do think that it's interesting to consider broadening the type of regulatory oversight that the Attorney General has in regards to nonprofit health facility transactions. And I think that the role of the Attorney General in that particular setting is born out of her unique role that she is the official safeguard of charitable trust in the state of California. So I would first of all certainly say that we would not be building upon that existing infrastructure, because we would be deviating from kind of the core mission of defending public benefit assets. And that being said, with the Massachusetts model, were there to be some sort of standing oversight entity that would provide greater transparency transparency. Their model incorporates their attorney general as part of that process, and obviously that's the sort of role that we'd be happy to look into participating in. And I would say that one of the real benefits of our nonprofit health facility transaction process is the fact that over the course of the review period, we have two different components to that. One component to that is we do contract with a healthcare impact expert. And this is an independent consultant who provides an objective review of what sort of impact a particular transaction would have on the surrounding community. And that's done through interviews with experts, then also through the institutional expertise of that contractor. But I also want to flag that the second very critical component of that is that we hold, as do our colleagues in other agencies, we hold public meetings where we solicit comments from community members who would be impacted by that transaction. So I think that, having both of those different types of models of both having expert opinions and then also having a better understanding of what a particular healthcare player's role in a community looks like is a really important part of that transaction. So while I wouldn't necessarily say that the AG's nonprofit hospital transaction review process is necessarily kind of a scalable infrastructure for these issues, I think that there are a lot of lessons to be learned from it in addition to what we've seen from the Massachusetts model.
Thank you. So question both to the Department of Managed Healthcare and the Department of Insurance. I know each one of you regulate and the various insurance markets that are within your purview. And I think the Department of Managed Healthcare talked about what they do for mergers as well as Department of Insurance. When you do that, and I know the Department of Insurance has hearings, and I wasn't sure if I heard if you have a hearing as well, but do you do that mindful of what the impact of cost is to the consumer? Is that one of the overriding thought processes for both of you?
So we're limited by what's in the Knox-Keene Act as to what we can review in terms of, some of the organizational changes and things that I mentioned. We don't have the capability to evaluate cost of care right now as these mergers. I mean, we talk to the plans, we get information from them about what they think the results are going to be, but we don't have the level of analysis like what Massachusetts was describing at this point. Right. So it's something that I'm concerned about. We have other tools that we use to try to address the cost issue around, like reviewing premium rates and evaluating networks to see whether if the narrow networks actually have high value providers and that kind of thing in it. But the cost specifically is not. The actual impact of cost on consumers, we can't really predict as a result.
Is that because of resources and what your limited scope with regard to how you're working within the Knox-Keene framework? Is that what's limiting you? Yes. Okay. Then to the Department of Insurance, I'm assuming you're not within the confines of Knox-Keene, and I would think that you're looking at what is the impact to consumers as far as their overall premium. So there's a little bit slightly different role, is that correct?
Right. The statutes governing this for the Department of Insurance and the Department of Managed Healthcare are just different structurally. And so we do look at what's in the interest of policyholders and the public, and absolutely affordability is an important component of that. And the academics and economists who talk to us, certainly tell us that when you get to a certain point in market concentration, that the history tells us that those players left standing are likely to exercise market power in ways that lead to price increases, that is the history, that with major health insurance mergers that you end up with increased premiums and out-of-pocket costs for the policyholders.
So, here's kind of how I'm seeing all these entities, whether it's the Department of Justice, which deals in a very narrow perspective of antitrust. You look at the number of antitrust cases, it's smaller, there's not a lot of them. The nonprofit hospitals, Department of Managed Healthcare, which is within the confines of Knox-Keene, you're obviously limited in resources. Department of Insurance, which looks at the market with health plans. But where is California lacking a collaboration of all these entities I guess the question I'm asking myself, should we have another entity like the Massachusetts model that we all kind of work together, where you can bring resources to make sure that all of these unintended consequences, whether it's plans, hospital mergers, provider groups, the sale of a drug company to another company so that they can, consolidate. At what point do we bring the resources to see, is this going to have a positive or a negative impact on consumers? And all of you are doing an incredible job in your respective agencies, but I guess the question we have to ask ourselves, and me as chair, is what do we do to solve that bigger picture? So I'm just making a statement right now. So I think all of you play a critical role in what you do, and that's why we're having this hearing. So with that, I want to thank all of you for being here. There was a lot of very interesting information that came out that we're going to take and look at and see how we're going to deal with potential market consolidations in the future and its effects on the consumer. So we're going to now move on to public comment. I think we have 3 individuals that would like to come up. We have Mr. Richard Grossman, Tam Ma, and Gil Ojeda. I thought Gil was in Chicago. Come on up. Please state your name, and please proceed.
Thank you, Mr. Chairman, and thank you for the opportunity to very briefly address the committee. My name is Richard Grossman. I am an antitrust attorney at the San Francisco law firm of Pillsbury & Coleman, and I am lead counsel in a case seeking to represent a class of self-funded health plans asserting antitrust and unfair competition claims against Sutter Health, the dominant healthcare provider in Northern California. There's been a very good discussion today of the urgent need for more robust antitrust enforcement in the healthcare industry. I would like to spend just a few minutes discussing one of the few examples of antitrust enforcement here in California in healthcare, public or private. I want to thank the Senate committee for its serious attention to the anti-competitive practices that have caused healthcare prices for the identical medical services to be nearly 40% higher in Northern California than in Southern California, where there's a more competitive healthcare market. These anti-competitive practices in Northern California have resulted in billions of dollars of illegal overcharges to patients and the Northern California employers whose self-funded health plans pay for their health care. As you know, employer self-funded health plans pay for their workers' health care directly out of their own funds without purchasing separate insurance. They account for more than 50% of the health care in California. However, they are victims of anti-competitive agreements between Northern California's dominant healthcare provider and the insurance companies that negotiate the prices for all provider networks. These agreements have provisions in them that have been discussed as anti-competitive here, primarily by Dr. Ginsburg earlier. These are agreements that impose punitive and unsustainable pricing on any health plan that does not include all Sutter hospitals and all Sutter medical groups in its provider network, even where higher quality, lower cost alternatives are available. That was the anti-competitive practice that Dr. Ginsburg referred to as all or nothing, something that he said needs to be addressed. These agreements between Sutter and the health insurance companies that arrange for all provider networks also forbid health plans from providing their patient enrollees with incentives to choose the higher quality and lower cost providers within the health plan's provider network. And this is the anti-competitive practice that was referred to by Dr. Ginsburg as anti-tiering provisions, where he suggested that perhaps tiered networks would provide more competitive pricing and lower healthcare costs. Tiering has been banned by agreement between Sutter Health, the dominant healthcare provider in Northern California, and the insurance companies that arrange the pricing for all healthcare networks. And these same agreements also forbid the disclosure of Sutter's higher prices to patients or their self-funded health plans that pay for their care, making it impossible for patients to know that there are more cost-effective alternatives when they select a provider. These anti-competitive agreements are the leading cause of the outrageously high cost of healthcare in Northern California, and the primary challenge for fixing our broken healthcare system, because they completely insulate the dominant healthcare provider from the discipline of price competition. Price competition, the primary engine of our free market economy. They have been condemned by policy statements of the Federal Trade Commission and the U.S. Department of Justice, but at the moment, the case that I am prosecuting is the only effort to stop these practices. I have heard from self-funded plans from across the region, health plans sponsored by our state's largest corporations and our state's largest employers, health plans sponsored by government entities that must pay for these higher healthcare costs, health plans sponsored by union healthcare trusts, and they all have the same question. They ask, where's the state of California on this issue? They point out that the Attorney General has been studying these illegal practices for nearly 4 years, but has failed to act. They ask, why hasn't the Attorney General utilized the antitrust laws to stop these anti-competitive practices? Frankly, I do not have a good answer to any of these questions. Anybody taking a serious look at these issues sees the same evidence that I have uncovered. Historically, Kathleen Foote and her antitrust section are widely recognized as California's most courageous defenders of competition in our free market system. There's no question about that. And yet our state regulators have been too timid to utilize their law enforcement powers to address the anti-competitive conduct that is now outrageously inflating healthcare costs. Because nothing has been done to rein in these anti-competitive practices, health insurance companies now seek further consolidation through mergers they hope will give them the power to counter the market dominance that certain providers have obtained through illegal anti-competitive conduct. But further market consolidation is not the answer to fighting monopoly power. The answer is enforcement of our antitrust laws. And every one of the previous speakers has talked about this, the need for more robust antitrust enforcement by the state of California and in private cases like my own. And so I call on you today to use your committee to proactively investigate these very same practices that you've heard testimony about from every single witness that's appeared before you today. And I ask you to do everything in your power to urge the Attorney General to take decisive action. My colleagues and I would be proud to stand shoulder to shoulder with the state of California in an effort to reintroduce healthy price competition into the healthcare market and dramatically lower healthcare costs for all Californians. Thank you, and happy to take any questions you have.
Thank you. Next, please, whatever order you choose.
I'm Gil Ojeda. I'm actually a scholar in residence with the California Program on Access to Care, having run the program for 18 years. And I wanted to comment on a couple of items. First, I'd like to acknowledge my real interest in the efforts of Director Seltz, okay? And what they've essentially done is built a very aggressive bully pulpit without definitive teeth, okay, of rate control, okay? And he acknowledged, in fact, in response to your direct question, he kind of equivocated, if you will. But the reason that Massachusetts went into this process, and the reason they passed Romney Care originally, is because the health care costs in Massachusetts are the largest per capita in the country, Okay, in fact, the largest per capita in the world, okay? So they were driven to a bipartisan system, and they have also driven to this issue of some sort of regulation or monitoring of the hospital systems. It is very likely ultimately that California is going to have to do the same, okay? Number one. Number two, in my role as Director of California Program and Access to Care in 2004 and 2005, there were two large mergers that came down, one in sequence. 2004, we had WellPoint Anthem. We formed the largest HMO in the country, and the following year, United Pacificare. They formed then the largest HMO in the country. And what happened is we had two regulators, the Department of Insurance, as well as the Department of Managed Healthcare, that both took different looks at this whole approach. And then in those days, in 2004, Department of Insurance became the more aggressive player. They were the ones that stood out. But they stood out, and they came out because the legislature acted as its own bully pulpit at the time. And they established a select committee on health insurance mergers that was under the leadership of then Speaker Nunez, okay, and Assemblyman Manny Diaz. Okay, and the insurance commissioner then, Garamendi, stepped up and said no. In fact, on July 23rd, I remember because it was my birthday, he said no, and for 4.5 months, they negotiated a series of undertakings that included public investments. And that's something that this committee should keep in mind, and the insurance regulators have discussed, this issues of regulating and enforcing, if you will, these investments to counteract some of the negative effect of these mergers, and that's an important role to play. I also should note that the then senator chair of Senate Health and Human Services, which is what they were called in those days, Deborah Ortiz, also played a role particularly in the Pacificare United merger, or Pacificare United merger of 2005. Okay, and they set a series of principles for reviewing these mergers, and I'll make that document available to the committee. The second thing that we should note is that because of that, and that both regulators noted the mergers at that period, and we do have a document that assesses the undertakings that were taken in both those cases and the potential impact on the current dialogue. So I would like to also make, as a final note, there's been some talk about why there's two regulators in the state of California. Okay, and I think that certainly the examples in 2004, 2005, as well as today, suggest that there's a role for what Galbraith used to call countervailing powers, of this distinct role of two agencies playing a role, one of which reports to an elected official, okay, and the other which reports to a department which is actually housed within the state government. At least in 2004, 2005, the governor at that time restricted the ability of the Department of Managed Healthcare to act. And then that's why they were behind the 8 ball, if you will, and the insurance commissioner acted first. Thank you.
Good afternoon, Mr. Chair. My name is Tam Ma, and I'm Policy Counsel at Health Access California, the statewide consumer advocacy coalition working for quality, affordable health care for all Californians. Health Access has been actively engaged with health insurer mergers and nonprofit hospital transactions here in California. We have asked regulators to impose strong conditions on any approval of mergers to ensure that consumer interests are protected. I can tell you, after having been to all of the hearings that the regulators have held, that we have not had the kind of information, analysis, and public discourse that exists in Massachusetts, and that's something that we would love to have here in California. First, I'd like to highlight 4 major points today. First, consumers must benefit from mergers, and the burden should be on the merging entities to show that consolidation is good for consumers. Companies that are merging must almost always say that the merger will lead to efficiencies and savings. It's never clear if these benefits, however, actually materialize, and if they do, if they are passed on to consumers. Those that are merging must show that merger not only does no harm to consumers, but that consumers will actually benefit in the form of lower costs and higher quality care. Providers and insurers should not be allowed to get bigger unless they get better. We need to look at their track record to see if they've met their statutory and contractual obligations to provide quality care. If they have major deficiencies, then they should not be allowed to get bigger until those problems are fixed. Regulators should require commitments and investments targeted at improving cost, quality, and value. A merger must also be good for the healthcare system as a whole and the communities that are affected. We think the detailed analysis that is done in Massachusetts is needed here in California. Right now, as Mr. Sumner described, the Attorney General prepares an independent healthcare impact statement that is used to determine if a nonprofit hospital transaction would have a significant effect on the availability or accessibility of healthcare services in a community. Such an analysis should be done for all healthcare mergers. Second, we need oversight over these important changes to our healthcare system to ensure that California maintains a robust and competitive market that delivers high quality and affordable care. Given the local nature of healthcare markets, state regulation and oversight is absolutely necessary. While there is some oversight over insurer consolidation, a large swath of health industry mergers, such as consolidation amongst medical groups and vertical integration between hospitals and providers, currently fly under the regulatory radar. California's current regulatory framework needs to adapt to some of these new conglomerations so that with risk and responsibility come regulation. Although integration can better coordinate care and reduce unnecessary spending, it can also lead to further consolidation, higher prices, and less accountability. The state needs a defined process to review these transactions, both from an antitrust and a consumer protection lens, and there should be ongoing oversight after a merger is completed to ensure that they are beneficial to the health system. Third, oversight of mergers must be public and transparent. Consumer advocates appreciate that both DMHC and CDI have held public meetings or hearings on the proposed insurer mergers. We must note, however, that in most of these cases, these agencies are not required to actually hold these public meetings. Mergers raise a lot of questions and concerns about their effect on patients and the public interest. We think merging companies should directly address these questions in public and not behind closed-door conversations with the regulators. Again, a more comprehensive process like what exists in Massachusetts would be of a tremendous value here in California. Finally, California has done a tremendous job of implementing the Affordable Care Act, and we've reduced our uninsured rate by half so far. The long-term success of the Affordable Care Act and our health system as a whole depends on whether we're able to rein in healthcare costs and improve value and health equity over the long run. History and research has shown that mergers tend to lead to higher costs for consumers, and there is no evidence that they lead to better value. As a result, the state must provide effective oversight over market consolidation and ensure that these changes strengthen and not undermine our healthcare system. Thanks very much, Mr. Chair, for holding this hearing today, and we look forward to working with you to improve the state's regulatory oversight over these consolidations and mergers.
Mr. Chair and members, Sarah Phlox, California Labor Federation. I just wanted to first thank you and your staff and all the speakers for a really excellent hearing. I want to go and either go to Massachusetts or read more about what they're doing. I thought it was just fascinating. But I'm actually going to focus my comments on some of the things that were said by Mr. Sumner, by Professor Ginsburg, and by Mr. Grossman. It's great that he came up and spoke a little bit about the lawsuit that he's working on, because the Labor Federation represents self-funded, self-insured union trust funds who are very sensitive to cost increases and have really been struggling with the rising cost of health care. And in response, we've tried to adapt by instituting cost containment measures. So we've done things like tiering, narrowing our networks, excluding these high-cost, low-quality providers. We've done things like reference pricing. We've tried to create incentives so that our members are going to the providers that are the lowest cost, but also the highest quality. So we're really looking at how do we get high value healthcare. And that's been something that our trust administrators and trustees have been working very hard to do. One, so that we can keep down our premiums in our healthcare, but also because we have a responsibility to the health and well-being of our members. When we have anti-competitive contracting practices that were outlined in some of the presentations, it makes it impossible for us to do that. When we have all or nothing clauses, it means that in areas where we have a provider that is very expensive, but not very high quality, we still have to have them in the network. We can't create incentives for our members to go to better providers. We can't do many of the things that we've tried to do so that we can save money so we can put that back into our members' pockets in the form of wages. And so this is a real problem across the state of California and beyond the lawsuits that are happening. And it's something that we hope we can find some solution to, because it is blocking the one avenue we have as purchasers to really create a high-value healthcare system. So we would hope that this is a start to a longer conversation. There's many things we want to talk about coming out of this hearing, so once again, thank you very much, and we appreciate the time.
Good afternoon, Chair. Linda Way with Western Center on Law and Poverty. First, would like to thank you for hosting this hearing and align our comments with health access, but also ask that particular attention be paid to health access for Medi-Cal and other low-income consumers. And again, would like to thank you for hosting this hearing.
Thank you. Seeing no other public comment, I'd like to again thank all the presenters who came out this afternoon and all the comments that were made. And with that, we're adjourned.